Am I audible to all?
Yes, ma'am.
Yes, ma'am.
Everybody can see the PPT.
Yes, ma'am.
So today we will be discussing about management of class 2 malocclusion. I hope everybody is aware of what is class 2 malocclusion. So what is class 2 molar relation? Okay, a class 2 molar relation is when distobuccal cusp of upper molar, first molar, is occluding in the mesobuccal groove of the lower first molar. This is class 2 molar relationship. But what is class 2 malocclusion? According to Angle, there are three classes: class 1, class 2, and class 3. This is an ideal relations of uh, molars. Fine. So now what is class 2 malocclusion? Class 2 malocclusion is a malocclusion which is having a class 2 molar relation. So what all things you will be seeing in class 2 uh, malocclusion. So when the patient is having class 2 malocclusion, patient will be exhibiting, when you check it dentally, the clinical findings will be, there will be class 2 molar relation, upper first molars, distobuccal cusp will be occluding in the mesobuccal groove of lower first molar. Then patient will be having proclined upper incisors. That means there will be proclination of maxilla, retroclination of lower incisors, or the lower incisors can be proclined. Then there could be crowding, there could be proclination, there could be spacing, but with class 2 molar relation. That this is class 2 malocclusion, a dental class 2 malocclusion. There will be a narrow maxillary arch, and profile changes as the patient is class 2 malocclusion. Patient has in class 2 malocclusion. That means patient must be having proclined upper incisors or proclined maxilla. So there will be a convex profile. Everybody is aware of profiles. There are three types of profile: straight, convex, and concave. Straight will be in class 2 due to, and when straight is near to ideal, it is considered as an ideal straight profile. Then convex when you have retrognathic mandible or prognathic maxilla. So there will be a convex profile. Concave profile when your mandible is prognathic and maxilla is retrognathic, that is concave profile. So basically, when you see a class 2 malocclusion patient will be exhibiting class 2 molar relationship, then proclination of upper incisor or maxillary prognathism, mandibular retrognathism. There could be proclined lower anteriors also. There could be crowding, spacing. Profile will be, there will be no lip seal. As upper incisors are proclined, their patient is unable to seal the lips. Okay. Convex profile. Then uh, upper lip will be short. Upper lip will be short. Retrognathic mandible, convex profile. So this is basic identification of class 2 malocclusion. Now, in detail, dental features of class 2 development. Again, this class 2 malocclusion is again divided as class 1 and class 2 div 1 and class 2 div 2. So we'll see in detail. In class 2 div 1, there will be proclined upper incisors. Upper incisors or the maxilla will be prognathic. Lower incisors could be retroclined or upright or proclined. There could be crowding, spacing. When you see the profile, if everybody can see the arrow, can everybody see the arrow?
Yes, ma'am.
Okay. So this is how you will find out a convex profile. Okay. A line which is passing from the nasion, base of nasion, to the upper lip. There is a point on the upper lip. You must not be aware of cephalometric analysis. Is that chapter over? Cephalometric analysis for the new batch?
No, ma'am.
Not yet. So a line which is passing from a point on the frontonasal suture to the a point on the upper lip, one line, and then other line, a tangent line which is touching to the lower lip and the chin. So this two line will be meeting at a point. When this angle is convex, it is an convex profile. So class 2 div 1 will be showing a convex profile, incompetent lips, prognathic maxilla. Then there could be a lip trap. What is a lip trap? So when your maxillary anteriors are proclined and your lower lip will be hiding behind the upper incisors. The upper incisors will not allow your lip to close, be in contact with the upper lip. So this is lip trap. It can be leading to trauma to lower lip. In these cases, you can find there will be a deep bite. Okay, so your lower incisors will be touching to the palate. They will be in contact with the palate, so there will be a trauma in the palate. So, what are the dental features of class 2 div 1? Procline upper incisors, there will be a large overjet, increased overjet, then crowding, spacing, anything could be there. There will be a lip trap, trauma to palate due to impingement of lower incisors. Skeletally or profile, no lip seal, convex profile, retrognathic mandible, prognathic maxilla. Then the skeletal features of class 2. When you will say that it is a skeletal class 2, when your upper arch, the upper skeletal base, that means maxilla is prognathic, or when your lower base, that means mandible is retrognathic, then or you can say posteriorly placed than the maxilla, or in combination of both when there is retrognathic mandible and prognathic maxilla. So what are the skeletal features? Prognathic maxilla, retrognathic mandible, or combination of both, retrognathic mandible and prognathic maxilla. Now coming to the etiology, prenatal, natal and postnatal. Prenatal factors, some studies have shown that the position of fetus or any abnormalities during the formation of pharyngeal arches will lead to class 2 malocclusion. Natal factors, trauma during pregnancy or during the birth. Postnatal, again trauma or any abnormal habits like thumb sucking, mouth breathing, etc. Now, coming to the treatment modalities, how to manage this class 2 malocclusion. Okay, this is very commonly faced malocclusion in during our clinics. So there are some objectives to correct this malocclusion. First will be reduction of overjet, then reduction of overbite, crowding and local irregularities, then correction of unstable molar relations, correction of posterior crossbite, normalizing the musculature. So when you are treating the class 2 malocclusion, you will have to consider these all objectives, and accordingly you will plan your treatment modalities. So there are three types of treatment modalities to correct a class 2. First is growth modulation, then camouflage and surgical corrections. We'll see in detail what is it, growth modulations. So now I have just told you that you will have to consider the objectives. Okay, when a patient which is still in growing phase comes to you and patient is having a increased overbite, overjet, and retrognathic mandible, so you can think of growth modulation. What is growth modulation? Growth modulation is you will allow or you will accelerate the growth of the bone, which is not matching to the age. That means if the patient is, suppose, for example, mandible. Okay, in class 2, there will be a retrographic mandible. So you can accelerate the growth of mandible and reduce the overjet and correct the overbite also. In when the patient is in growing phase. So there are some appliances like pin block, then frankel, activator, and bionator. These appliances are used to modulate the growth. What does this appliance do? So this appliance will apply some traction or some stress on the lower jaw. Without this appliance, this jaw will close in class 2. That means it will be far behind the upper incisors. So when you wear this appliance, it will forcefully this the jaw will close in class 1 relation. That means there will be a class 1 molar relation. These blocks will not allow the mandible to fall forward, fall behind. Like this. These are growth modulations. Then you can stop. Uh, Growth modulations can be considered in two ways. One, allowing growth, and second is to stopping growth. Allowing growth will be from myofunctional appliances like twin block, activator, bionator, and triangle. Then there is something called as orthopedic appliance. Or what this orthopedic appliance will do, it will help in stopping the growth or restricting the growth. It can also help uh, in promote the growth, but when you are treating the class 2 malocclusion, when upper incisor or upper arch is prognathic, maxilla is prognathic, mandible is retrographic, you will try to pull forward the mandible and stop the growth of maxilla. For stopping growth, you will use headgears. Fine. There are different types of headgears. This will be your duty or your homework to find out what are the orthopedic appliances and what are the myofunctional appliances and how they are used. Now, same as the myofunctional appliances, there is something called as fixed functional appliances. You will use myofunctional appliances when the patient is still in growing phase, or there are some potentials of growth according to the SMI phase. You have done with the SMIs. Am I right? Everybody sleeping? Okay, fine. So when your SMI, when your hand risk, you see the hand risk analysis, and still the patient has some potentials of growth, or it is in peak growth, you can use myofunctional appliances. Okay. In last phase of peak growth, when the growth is nearly to complete, you can go for fixed functional appliances. Myofunctional appliances are removable. These fixed functional appliances are fixed. So they are used at the last stage of growth. For some examples, Mara appliance, the Herbst appliance, and the uh, fixed functional appliances, the forces appliance. So these are appliances which will forcefully pull the mandible forward to correct the molar relation, to correct the overjet and correct the overbite. Then coming to camouflage. When you will consider to camouflage, what is an camouflage? So when patient is beyond the growth phase and patient is having moderate skeletal features, there are degrees of everything like mild, severe, and moderate. So, when mild cases, moderate cases, you can treat with camouflage. Those patients who have completed the growth, the adult patient, mild to moderate cases, there should be well aligned teeth or good vertical facial proportions. So mild to moderate class 2 cases, we can treat with camouflage. So what is an camouflage? Camouflage is an masking of something. Okay. So there will be a malocclusion, but you will mask the malocclusion. That means you will correct the profile. or will not completely correct the malocclusion, but it will look good. Fine. Like a makeup. After makeup, we look really beautiful. That is camouflage, hiding our defects. Understood? So, extraction has a main important role in camouflage. We cannot do camouflage without extraction. So, camouflage is done in patients who are adult. Then they need minimum space to correct the malocclusion. In these cases, we'll think of extractions. So, which tooth to extract and when to extract. Now, if the patient is having severe crowding and class 2 molar relation, here we can think of there is not necessary to correct the molar relation. If it is a full-fledged class 2, we can keep that class 2 molar relation as it is. We will not disturb it. But if it is an end-on or it is beyond class 2 or it is towards class 1, we'll have to stabilize it either in class 2 or in class 1. So now coming to extraction, there are different protocols of extraction. Most likely will extract upper premolars and lower premolars. Which premolar to extract when? So in some cases, we can extract all four premolars. See here, like this. All four premolars. Then you will relieve the crowding or correct the proclination and close the space. In some cases, when when there is increased overjet, so in these cases we can extract only upper first premolars to reduce the jet, reduce the overjet, because lower arch is well aligned and there is no need to correct. There is no malocclusion in lower arch. In these cases, to correct the overjet, will extract the upper 4 only. So then in some cases, when you need to correct the class 2 molar relationship, when there is a minimum need of space, so you will go for extraction of upper 4 and lower 5. Upper 4 and lower 5. Why lower 5? Why upper 4? So, if you extract the upper 4, there will be no threat of this molar to move in the extraction space. There will be a minimum threat. Okay, but you want to correct the class 2 molar relations. So you need to allow this lower molar to migrate or shift in the mesial side. So you will extract lower 5, so that will be easier to protract the molars, lower molar, and correct the malocclusion. Fine. So what are the, in some cases, the minimum to moderate anchorage cases where you need minimum spaces or moderate space, you can go for all 5 extractions. So what are the extraction planning? All 4, all 5, upper 4, lower 5. This is very important for your model analysis thing. Every time you will make some mistakes during this. When there is a class 2 molar relation, when you are going to treat a class 2 molar relation, when there is minimum need of space, please go for upper 4 and lower 5. This lower 5 will correct your molar relation. Fine. Then after creating the space with extraction, we'll have to close that space. How to close that space? So there are different appliances in removable and fixed appliance. So here I have only discussed this. I'm discussing only about the fixed appliance. In removable, you can go for penile retractors and labial bows to close the space. In fixed appliance, there are some different types of loops like this teardrop loop, omega loop, then the T-spring. These loops, they are wire bending. They are bended in the wire and then activated to close the spaces. Then there is E-chain. So this E-chain is applied to a hook and the molar hook and allowed to retract the anteriors. Then a open coil spring. Sorry, closed coil spring. A closed coil spring is stretched from an implant placed in a maxilla and to the hook. These are some ways of space closure. Then, if the patient exhibits that there is no need of extraction, there is not much need of extraction, we can think of distalization. What is distalization? When you want to correct the molar relation, either you will have to protract the lower molar or distalize the upper molar to correct the class 2 in class 1. So when there is no need of extraction, you can go for, when there is more minimum need of space, you can go for distalization in upper arch. So there are some appliances like pendulum appliance, then the K-loop, and then the implants. With this, you can distalize the molar, create the space, and retract the upper anteriors. So this is in fixed treatment, fixed appliance treatment. What appliances are used to distalize upper arch or upper molars in removable appliances? Anybody can answer this? Fine. Everybody is sleeping now? This will be your homework. Find out which appliances are used to distalize in upper arch, because this is very important for your model analysis. Most probably in from next week you will be starting your model analysis at home. Now, elastics, class 2 elastics. When there when there is a unstable molar relation, it is not full-fledged class 2 and you need to correct it in class 1. So you will be giving a class 2 elastic, which is extending from the upper canine hook to the lower molar hook. This class 2 elastic can correct, this will mesialize the lower arch and distalize the upper arch to correct the class 2 molar relation. So in camouflage, there are extractions, distalization, and class elastics. So extraction of all four, upper four, lower five, all five. Distalization with different appliances. What appliances should be used in removable appliance to distalize, you will find out. And then the class elastics. Moving forward, sorry for the spelling mistakes. Till now, we have seen growth modulations, then camouflage, and the third treatment modality will be surgical corrections. When there is a severe skeletal malformation and there is severe skeletal malformation in adult patient, we'll consider this case for surgical correction. How you will correct it surgically? So when patient is having, there are two ways of correcting it surgically. Either, three ways, either upper arch surgery or lower arch surgery or combination of both. So when patient is having a long face, there is a massive gummy smile. In these cases, and deep bite. In these cases, you will think of lifting this arch upwards so that there will be reduction of gums while smiling or talking. There will be correction of deep bite. So this is called as impaction, maxillary impaction, surgical impaction. Then, or when you need to impact this jaw and still there will be a, there is overjet remaining. So impaction and reduction. Okay, so you will move this upper arch, will cut the upper arch, move upward and backward. So there will be correction of overjet also. In some cases, when there is no need of upper arch surgery, we'll go for advancement of lower arch. You will apply plating and grafting and advance the lower arch to, in order to reduce the overjet. Then here you can see. So the third way is, if patient is not, patient doesn't want the massive surgeries or this much surgical procedures, but still want to correct the facial profile when there is a receding chin. So if you advance this chin, advancement genioplasty, patient's profile will be pleasant or corrected. So according to patient's need and according to your cephalometric analysis and skeletal analysis, you will decide your treatment plan. So in surgical treatment, so there are now three uh, treatment modalities we have. First will be growth modulations, then camouflage, and then surgical corrections. In surgical correction, either impaction or reduction of upper jaw, advancement of lower jaw, or combination of both, or else advancement genoplasty. Most commonly, your class 2 patient will exhibit uh, deep bite and cross bites. Okay, how to reduce this deep bite? This deep bite in removable appliances can be reduced by bite plate. Again, this is an homework or find out what is bite plate effect. This is most likely Viva question. What is bite plate effect? Right. So in removable appliance, you will use upper anterior bite plate. In fixed appliances, some loops like Kaiser arch or intrusion arches or implant to intrude the upper incisors so that this segment will be lifted upwards and there will be reduction of overbite. Understood? Then the crossbite. Cross, always these class 2 patients will show a narrow arch. To correct this narrow arch, we'll have to expand the buccal segment. So in removable appliances, jack screw and fixed cord helix, IRX, or a NITA expander can be used. Now coming to class 2 duty. Till now we have seen about class 2 div 1. Class 2 div 1 has a bit difference than the class 2 div 2. In class 2 div 1, you have procline upper incisors, but in class 2 div 1, sorry div 2, there will be retrocline upper incisors and procline lateral incisors. Fine. In class 2 div 1, there will be a convex profile. Okay, but here in class 2, due, uh, due to there will be nearly a straight profile, broad upper arches. In class 2 div 1, there will be narrow upper arches like this. So the clinical features, the dental features will be retrocline upper incisors and procline lateral incisors, class 2 molar relation, broad dental arches, and deep bite. Facial profile will be nearly straight, broad squarish face, and there will be a complete lip seal. Correction of class 2 due to first thing will be to correct the retroclination of upper incisors. You can do it with removable appliance with thread spring or in fixed appliances by applying brackets and wire. Then after correcting this retroclination of upper incisors, sometimes what happens, sometimes what I'm sorry, everybody can see the PPT.
No, ma'am.
Now you can see the PPT.
Yes,
Yes.
ma'am.
Okay, fine. So when you are treating a class 2 due to case, after correcting the upper incisor proclination, sorry, retroclination, sometimes what happens, because of this retrocline upper incisor, this upper incisors will restrict the mandible to grow. They will not allow mandible to grow. Once this hindrance is over, the upper incisors are proclined or they are in uh, complete arch form. So there is some space for mandible to grow. Suddenly this mandible will jump up and acquire a class 1 skeletal profile. I hope you understand that if this not happens, we will have to correct the lower jaw by applying fixed functional appliance to bring it forward. After correcting this hindrance, this retrocline upper incisors, mandible will jump up, or else we'll have to apply some uh, growth modulations like fixed functional to correct the jaw relation. Then, if the patient is having crowding, the class in the class to do, we'll have to go for extraction. So this is the end of the chapter. This is very important chapter for exam going students or for your exam. So there will be some tricky questions like they will give some cephalometric values as a SNA angle is more than 2 and patient is having incomplete lip seal. So what treatment modalities will you? So you will have to think what is uh, SNA angle beyond 2. So it will be a class 2 SNA angle. You will be knowing this or you will get to know this when we teach you the cephalometrics. And then incomplete lip seal is in class 2 div 1. It is not in class 2 div. So you will have to differentiate the thing and then write the answers. Fine. So there is a message for the winter batch, sorry, the odd batch. You will be having a class on model analysis very soon, maybe in this week or the next week. So we'll be giving demo of model analysis, and then if everybody has their cast and their everything with you, do you have at home?
No, ma'am.
No, ma'am.
Yeah, the simple thing, the car dividers and scale and pencil and book, this must be you all have it. So we will
Yes.
give some values. We will measure the cast for you. We'll provide the values, and you will be doing the model analysis and sending back to the any one from us. We'll give the number or mail ID. You will have to send that. Fine. So most probably from this week we are going to do that. First, there will be a demo. Then you will have to perform model analysis at your own at home. Fine.
Okay.
Yes, ma'am.
Okay. Thank you.